Awesome. We'll get started now. Thank you everyone for joining. My name is Stephanie Rubenstein. I'm a former nurse I am a nurse and a former stroke coordinator at a local South Florida hospital, Comprehensive Stroke Center. I've been with Viz for the last 4.5 years. I serve as a senior clinical manager here, and I've been focusing on uncovering the brain-heart connection, building Viz Connect. I'm so proud to be introducing Dr. Brett Meyer, who's the co-director at UCSD Stroke Center and the clinical director of telehealth, and also Dr. Jonathan Hsu, who's a cardiac electrophysiologist and a professor of clinical medicine, also at UCSD. Just to give you a quick background, Viz.ai is an AI healthcare technology platform set out to improve patient access to life-saving treatment. We are the proven AI platform for stroke, and more lately, venturing into other disease states. We put patients and providers first. We're focused on clinical workflow improvement and improving patient outcomes. And just some statistics on the screen, we have over 45,000 active users in over 1,600 hospitals and health systems. We have over 30 care pathways and over 13 FDA-approved algorithms. Our providers are delighted, as you can see on the left. We have over 90% of our Viz.ai alerts viewed within 5 minutes. We were the first de novo cleared FDA approval for AI in 2018. And I am happy to introduce, let's go through a quick background on how Viz works. Viz.ai ingests imaging and projects it on a smartphone. We run our AI algorithms through the images, and whatever AI algorithm is live at that institution, it will detect it and alert those associated care team members. From there, Viz.ai has a very intuitive HIPAA-compliant communication hub. Our CEO, Dr. Chris Mancy, will say, if Epic is your system of record, Viz is your system of action. The AI is only as good as the workflow attached to it, and that's the best part of Viz, in my opinion, is the HIPAA-compliant communication hub. We have spent the last 2 years learning from healthcare providers in the neuro and cardio fields to learn how we can continue to improve patient care through the continuum, firstly, within the inpatient post-acute stroke setting. So up until Viz Connect, Viz sort of stopped at the decision to treat in the hyperacute stroke space. And we've spent the last 2.5 years learning how we can bridge Viz into the post-acute stroke setting in support initially of cryptogenic stroke patients and ESUS patients. There are too many patients that leave the hospital without a known cause of stroke or clear path forward. And after a 2-year field analysis within the country, we uncovered the delays in patient referral to cardiology. We looked at solutions to improve patients lost to follow-up, and we are looking at reducing the risk of secondary stroke. So we built out a platform called Viz Connect. We piloted this initially in 10 sites across the country. And I'll walk you through a very quick use case. If you have 20 patients in your inpatient stroke unit, statistics say that at least 10 of them will need a cardiologist for one reason or another. And focusing on those patients that need implantable loop recorders and external monitors first, we built out a seamless magic button to get the neurologist to the cardiologist and really support that neurocardiology relationship. So in a nutshell, if you start from the left, you would select that patient that's already populated within your Viz application, and you would intuitively click the cardiac management button, whether you're at the patient's bedside or you're surrounding a workstation. You would then click the presumed etiology of stroke. In this case, it's cryptogenic stroke with suspected AFib. And you would select the indication for referral, whether it be an implantable loop recorder, an external monitor, a transesophageal echo, or a combination of things. And in an instant, the imaging, along with the patient information and all of those things, is bundled up and sent immediately to the on-call cardiology or EP teams, also the advanced practice provider teams. And we were able to see in about 1.5 years, over 1,500 referrals sent from neurology to cardiology in our pilot sites, UCSD being one of them. We were able to improve patient outcomes by 50%. We were able to reduce delays in diagnosis with a less than 5-minute average response time from EP. And we were able to do a 10x increase in patients referred for cardiac monitoring. This has proven to really clean up the coordination of care in the post-acute stroke setting. This is only where we're starting. We plan to go more places. But I'm really excited to be introducing Dr. Meyer and Dr. Hsu to talk about their experience with Viz Connect. And there's an opportunity to ask questions at the end. So, Dr. Meyer, from a neurology perspective, what has been the value add of Viz Connect to your stroke workflow?
There's a lot to that question about value add of Viz Connect, first of all, you have the coordination of a acute care for or from acute care to a post-acute stroke patient, and then you have the second part of that, which is the value add of Viz Connect itself. So let me sort of break that down a little bit to the first part, which is the critical importance of coordinating care for post-acute stroke patients. The issue there is one of provider focus and really the spectrum of stroke care. We're providers. We're expected to do a lot. We're expected to do it all. The focus has historically been on the hyperacute stroke patient, right? We've done the LVO assessments, the AI algorithm applied to CT, CTA, CT perfusion to look for salvageable brain tissue, and we're good at that. In fact, in our shop, we took a very good program with robust neurointerventionalists, and we improved care neuro-IR KPIs by 30 to 39% in the acute landscape. But the natural next step of that evaluation is the neurovascular or cardiac interface, aka, as you pointed out, the ESIS patient or the cryptogenic stroke patient or the patient with the underlying arrhythmia. So it's important to sort of shift our focus from that hyperacute moment to the post-acute moment before we can talk about what the value add is of Viz Connect particularly, so which is what the question is. So to that question directly, I think we got to go discuss what Viz Connect really is to me as a provider. I mean, you presented what the concept is, but to me, it's a platform that allows us to have direct, immediate, early provider-to-provider conversation to get the ball across the goal line. There's a lot of things that we're expected to do, but one of our problems is we have so much technology sometimes in the way that we just lose the ability to communicate. I mean, John Hsu, who's here with me now, we've had a long relationship, and yet, we have historically referred patients in this third space ether nebulous world. And I think that Viz Connect, the value out of Viz Connect is it brought back that provider-to-provider communication moment. I mean, we've all had the experience, again, talking from a provider perspective here, which is what I'm talking about and what I'm talking to. We've all had the experience where we put in a consult into the computer system. We would hope that magically it would do what it needs to do and get to the right person, and someone would assess the patient and get back to us and give that consulting answer. But it was all done sort of put it in the machine and hope the machine spit back out the answer. The Connect platform changed all that for me. I'm going to talk to you about my opinions and how I got involved in it and what I thought about it probably later on. But to me, it allowed us to get that question asked and that reply back within 5 minutes, with the discussion. You mentioned something in your front end talk, which is interesting because my comment is always the proverbial easy button, right? It's the easy button for us to get that communication connections back and forth between the providers. So we're going to talk about the data, of course, I'm sure, but in my mind, the value add is simple. It makes my life better. It made my work better. It made the patient's life better. It made the provider's life better. How did it do that? Well, first of all, it extended our care from the Viz LVO neurostroke workflow into the cardiology workflow for the cryptogenic stroke patient. Second, it improved the closed loop communication. I just talked about that with Dr. Hsu and his team and myself. It obviously, when we talked about the data, improved our number of referrals and our time to device placements exponentially. And it made things simple for us. It was just really an ask and an answer. Ask the question, whether it's, do I want an event monitor and a plannable loop recorder in either case? And we got our answer back quick. But the biggest, back to your original question, I'm good at giving long answers to short questions. Your question was, what's the value add? The biggest value add is that there's a huge burden of AFib in stroke. The data is now supporting that we have to go find it. In my mind, that's what this pathway does for us. It improves the monitoring of stroke patients for AFib, but it does so without making my life harder, without adding layers of complexity, without adding pain to my workflow. It's a simple, easy button that says, hey, I need your help, Dr. Hsu and team. Can you give me an event monitor or an ILR or what have you. So the value add for me is it works, it makes my life better, it makes the patient's life better, and it helps me take care of stroke patients looking for cryptogenic stroke and atrial fibrillation.
Thank you, Dr. Meyer. Now, Dr. Hsu, why is this of value to cardiology?
Yeah, thanks, Stephanie and Dr. Meyer. That's a long-winded answer, and I'm happy to give one. But basically, what we're trying to do is really provide good care for our patients and good service to our stroke neurologists who are also trying to provide good care to their patients. Really, I think the first part of that question and answering that from a cardiology perspective is that really by using Viz Connect, it really simplifies and makes more efficient the communication of patient information from the neurostroke service who are taking care of this patient in an acute stroke setting and have multiple services that they are either consulting or dealing with in the acute care of these patients, and allowing that communication to us as a service consultation, such as cardiology or EP, for consideration of further care, including looking for atrial fibrillation with either a continuous monitor or implantation of an implantable cardiac monitor, an implantable loop recorder. And this really allows for better planning and care for the patient in general. And it's really that communication piece that I think is really important. Now, again, neurostroke is really busy in taking care of these patients. And there are ways, as Dr. Meyer stated, of getting a hold of us either through a paging system, through the electronic medical record. But what we found was that Viz Connect really simplifies that communication piece and allows kind of two-way communication for us to seamlessly and efficiently communicate with each other for the care of our patients. So it's really as simple as that. When we talk about care coordination of these patients, really that's up to our stroke neurology colleagues to try to do that. And they're juggling a lot of different things. So by providing that service from a cardiology or EP's perspective, we're trying to simplify things for them that are taking care of this acute stroke patient. And, to make sure really that communication is not lost, that patient information can seamlessly be transmitted to us as individuals that are taking care of this patient, and that we can consider these important clinical steps from a cardiology perspective, including an external monitor if that's deemed to be important to them, or an implantable loop recorder. And really this, we think, provides ideal in-hospital treatment for these patients so that it simplifies the in-hospital treatment on their stroke neurology service, but also allows for post-discharge coordination of these patients and making sure that if they warrant something to be done in the hospital, such as a monitor or an implantable loop recorder, that it's done either at that time or prior to discharge, and then also allows that patient from a cardiology perspective to get that post-discharge coordination as well. So that communication allows seamless transition between the inpatient setting and a post-discharge coordination for that patient from a cardiology perspective, and that we can take care of them afterwards. So we have many examples at UCSD which have shown us that Viz Connect really allows us to provide the best care for our patients. Specifically for cardiology, for example, if Dr. Meyer on the stroke neurology service deems a patient necessary to have a need for implantable loop recorder to be implanted, basically on Viz Connect, that's communicated to us. We're able to get that early in that patient's stay, and therefore we get more efficient advance notice for our procedural day, so that if an implantable loop recorder is necessary, we can plan our procedural day to get that patient what they need either that day or quickly thereafter, so that the other things that are happening during that stroke neurology patient stay can be coordinated as well, because we understand that an implantable loop recorder procedure, we do need to plan in advance, but that we can plan around either that patient's discharge planning or other procedures that patient has. So this really allows for the best utilization of resources to get the patient really what they need. And from the cardiology perspective, really helping us plan our schedule around our busy procedural day as well. So again, in the end, really what we're trying to do is provide the best care from a cardiology EP perspective for our stroke patients. We understand that when patients present with ESIS or cryptogenic stroke, that when, it's really up to a neurologist to decide what kind of things are necessary from a stroke perspective. If they suspect atrial fibrillation, then certainly we want to provide that care either from a external cardiac monitor and implantable loop recorder. And from a cardiology perspective, in regards to this communication, referral volumes, and implantation volumes, it's really, really important that we provide this service in general. And it's really good for the cardiology department because we can provide these services efficiently and at the volume that is necessary that stroke neurology deems important.
Thank you, Dr. Hsu. Great answer. I'm going to take it back to Dr. Meyer. Could you tell us, Dr. Meyer, more about the clinical impact that you've seen in San Diego?
So clinical impact, that focuses more on a qualitative question and a qualitative question. So I'll start quantitative and qualitative. Let me start with qualitative. From a qualitative perspective, you sort of look at a clinical impact, and in order to look into it and see what kind of benefits you've received, you first have to realize you have a clinical problem that needs clinical improvement. And that's the funny part of this for me, is because what's the clinical impact? Well, if you had asked me a year ago, I would have told you we didn't have a clinical problem, so there should be no clinical impact. I didn't even realize that our system was not working. You say, what was your process to get an external monitor, an ILR? I'd say, well, our process is fine. We don't have a problem. It's very simple. We put in an order, we put in our EMR, we fill out the appropriate fields, it goes into the internet abyss, we hope for the best, and eventually the patient gets their magic monitor. And this is the part where I have to throw myself under the bus and admit that I was an absolute 100% naysayer. I did not think we needed this product. I did not think we needed this pathway. I went kicking and screaming, and I am very happy to say that I was completely wrong. I'm completely wrong frequently, but in this case, I was completely wrong because our process was not working, and you only find that out when you do the clinical improvement assessment, which we did. So I always say, what is the best product, or what is the best workflow? What does it do for you? What does it solve? And the answer is always the same thing. It solves a problem that you need solved, but that's not the right answer. The right answer is it solves a problem that you either knew you had or didn't know you had, and then you can never live without it. And I think in this respect, the Viz Connect pathway solves a problem we didn't even know we had, and now we won't and can't go back because we can't live without it. The new way allows the direct communication that Dr. Hsu pointed out. We get an immediate response. We get, bilateral question and answers. We get an immediate intervention, which I'll talk more about. We went ahead and monitored it as our Connect product, or pathway, which stood for Coordinating Options for Neurovascular Patients Needing Electrophysiology Consults and Treatments. That's what Connect stands for us. But basically, we have neurovascular patients that need EP, and we get the consults this way. So as Dr. Hsu pointed out, and I'm going to dovetail to the thing you just said, John, which is, I send a text, or on the HIPAA compliant communications portal, I send a message, hey, I have a 50-year-old patient here with ESIS. His uncle had AFib. I think, he's probably going to have it. Can you put in an ILR? But he's got an echocardiogram today at 3 o'clock, and he's leaving today at 6. And so, Dr. Hsu is able to say, move around his day if possible, and say, yeah, I'll place it at 5. And I've had, 100 examples of this kind of thing. And we'll talk about the data now, but from a qualitative standpoint, it's made my day better. From a quantitative standpoint, it solved a problem I didn't know I have. And how do I know that? With the quantitative answer about what does our data show. So our experience is great. We've always had a good relationship with cardiology, and full disclosure, our stroke clinic is literally in the cardiovascular center. So I wouldn't say you could find a better example of two groups that have always worked closely together. And yet our data historically was not good because the system required that we put the consult into Epic or an EMR, and it would go through the normal pathway, and John and I couldn't communicate, or his team and my team couldn't communicate. So as far as the data goes, I like to say minutes to view, hours to place is better than weeks to view, and months to place. So it took a handful of minutes for the EP team to see the consult request, and our average time to get it placed was on the order of 5 to 7 hours. So same day prior to discharge. Rather than the old way, which is the consult would go out, it would be weeks before the right person scheduled it, hopefully into the right clinic, and probably 1 to 2 months before the ILR got placed through no fault of electrophysiology team there available. It's just the way the system was. Our yield is exactly what you would expect based on the recent data, Crystal AF and Stroke AF, in terms of what percentage of atrial fibrillation we're finding with these monitors. But we know what the data is telling us. The data is slowly telling us that we need to start monitoring these people more. And I think that means we need to start monitoring these people quicker, which adds another wrinkle to the timeliness data, right? Assuming, for instance, you want to get an ILR placed. Getting it done prior to discharge to me is critical, not just because you're saving the 1 month of time of monitoring, okay? Irrespective of that you start monitoring quicker. The real thing is if I send a patient out with a event monitor or not, and I plan to eventually get them an ILR, well, that patient has to go back in the real world, and life tends to intrude, and they no longer have the luxury of focusing on their own care because they're focusing on family and friends and work and all these other things. And by the time we get to the point where John Hsu may see him in clinic and say, okay, Dr. Meyer, wants me to consider putting in an ILR, they may or may not even go to clinic. They may or may not even have time to get the ILR placed, or they may think, well, if it was important, we would have done it acutely. So now it's 2 months later, maybe it's not so important. Final point on the data is the issue of a high tide raising all boats. I think that, to me, the great part about the data here is that our view of the implantable loop recorders data went up. I mean, we're averaging about 100 a year now. We did more in a 2-week period than we did in an entire previous year. But also the same thing's happening with event monitors. Implantable loop recorders, our numbers sort of tell the tale. We've done a lot of those prior to discharge, but event monitors also go up too. And it doesn't matter if it's event monitor type 1, 2, or 3, or brand ILR 1, 2, or 3, a high tide raises all boats. So before I turn it over, a quick point on the clinical impact. Why does it work? A good tool in healthcare needs to do 3 things: improve the care for my patients, make my workload better, and make my day easier. And I always say, if you ask for something and someone just says, here it is, you got something. So I wanted something that improved the care for my patients, made my day better, made my life easier. And someone just said, here, and I didn't have to do much work. I just opened it up, did what I needed to do to plug it in and get it started. And it was just that, here, just take it, it works. And that's pretty much what happened. So the clinical impact qualitatively was huge, made my life better. And quantitatively, the numbers tell the tale. We've improved both all of our monitor types and our timeliness data prior to discharge rather than in the outpatient setting.
Thank you, Dr. Meyer. I love the here analogy. That was great. Dr. Hsu, same question. What has been the clinical impact for you?
From a cardiology EP perspective, the clinical impact has been really getting the patients the care that they need from a cardiology perspective, and almost wondering, kind of, as Dr. Meyer said, like, where were these patients before? What we realized with Viz Connect was that these patients were really probably being lost in the system, and that this coordination of care communication was really getting these patients what they needed from the beginning. And it wasn't that neural stroke didn't realize that they needed these type of interventions. It wasn't us not trying to provide these interventions for our patients. It was really just providing the efficiency in order to accomplish this. And when we talk about the clinical impact and clinical care, we all know, what the guidelines state and what is probably best for our patients. If you look at the 2021, the most recent AHA guidelines on stroke specifically, they clearly give a 2A recommendation to consider long-term rhythm monitoring with either a cardiac outpatient telemetry system or an implantable loop recorder in patients with ESIS or cryptogenic stroke. So, the guidelines clearly support this. We know this as clinicians, that atrial fibrillation is certainly on the differential and highly likely in these patients that present with stroke as their presenting clinical feature. And we have randomized controlled trials showing with Embrace, with external monitoring, and Crystal AF. These are some of the original studies that show that monitoring for atrial fibrillation with cryptogenic stroke patients, when they show up on a neurostroke service doorstep, obviously we need to think about atrial fibrillation and monitoring, and as long as we can monitor, whether that be in the short term or in the long term, to detect patients with atrial fibrillation who are presenting as their first manifestation with stroke. You know, what's interesting with this data is that even further studies such as stroke AF in the neurostroke literature in the world, and that obviously encompasses us as cardiologists and EPs, that even patients with large or small vessel disease and stroke can benefit from monitoring and detecting atrial fibrillation, perhaps even increasing the amount of patients that really need monitoring in general, and maybe even understanding that atrial fibrillation as an entity is quite prevalent and presents in strokes in a myriad of different patients. And the clinical implications of this, you know, putting a monitor on and then detecting atrial fibrillation is profound, right? Because that patient then changes from antiplatelet therapy, which stroke neurologists know best, is the treatment of care for stroke. But then when atrial fibrillation is detected, that standard of care changes, and it's really oral anticoagulation. We know that, they know that. It's not that their data doesn't show that. It just shows that antiplatelet therapy is the best, and that really, if AF is detected, then that really warrants a change in the standard of care, which is then incumbent on the cardiologist and EP, which is also why we take ownership of these patients thereafter and at the time of their stroke admission when AF is suspected. So remember, if a patient gets a monitor and then atrial fibrillation is detected, as we discussed, the standard of care then is now atrial fibrillation, stroke risk reduction, and that tends to be historically and by guidelines, and what we do is starting oral anticoagulation lifelong. Let's just say that theoretic patient gets that. But remember, we as cardiologists and EP also understand, as we manage these patients on oral anticoagulation for the short-term, long-term, and potentially lifelong, that they may not be able to tolerate long-term oral anticoagulation. So then it is incumbent on us as clinicians, as cardiologists, then to consider other options. We do have other options in patients that perhaps present with cryptogenic stroke, then are determined to have atrial fibrillation on a monitor, and then are determined not to be able to tolerate long-term oral anticoagulation with such things as left atrial appendage occlusion. And of course, that's not expected that a stroke neurologist either does that at that time of admission or even suspects that, but you know, getting these patients that type of care with monitors and cardiology referral and follow-up allows us to not only take care of patients from a pharmacologic perspective, but allows us to consider procedural aspects of their cardiology care in the future, particularly in those that are detected with atrial fibrillation. I can give you a patient example of somebody actually that was sent to us by the neurostroke service at UCSD with cryptogenic stroke. This individual was started on antiplatelet therapy, as was guideline directed by the neurostroke service with cryptogenic stroke, had an ILR implanted during that admission, and then basically we remotely monitor this patient with an implantable loop recorder as an outpatient. He actually moved to Arizona on his antiplatelet therapy, and we monitored him remotely with our monthly remotes. And for 6 months, he had absolutely no arrhythmia at all. He actually lived in an RV in Arizona and was switching his care to a EP cardiologist in Arizona. So we were remotely monitoring him with his device in his RV. And he actually eventually had atrial fibrillation detected. We started oral anticoagulation, and we were monitoring that, but he was having difficulty. We're all managing this over the phone while he was trying to get established with an EP cardiologist. We ended up setting him up with an EP cardiologist in Arizona, and because he wasn't tolerating oral anticoagulation, they're actually considering left atrial appendage occlusion there before we handed him off to an EP cardiologist in Arizona. Just to go to show full circle how somebody presenting with cryptogenic stroke can get the full myriad of cardiology care from start to finish.
Thank you, Dr. Hsu. We're right at time here, but we have a bunch of really great questions in the chat.
I'll stay.
I just want to hit one of them, and then we'll send the rest out and we'll get them all addressed. But Dr. Meyer, I want to talk about the patient benefit. Can you just very briefly talk about the patient benefit?
Yeah, I'll do that in 30 seconds. It's not that we find more AFib. Obviously, you know, we want to monitor the patients. Obviously, that's a critical benefit. But in my mind, it's the fact that we now get to allow the patient to give their own input onto their care. In the old way of doing things, we would do an event monitor and then maybe send them out and then hopefully get an ILR in series. Now we get to do what we call Viz Organic, which is we have an organic conversation with the patient and say, hey, I now have the opportunity to put an ILR or an event monitor on you prior to discharge because we have this new slick system. Here's the ups and the downs of both of them, parallel processing, which one do you want? And I was 100% sure that they would all pick, you know, a non-invasive monitor, and that was not what happened. 60+% of our patients, I think it was 62% of our patients are opting for the ILR because we're now having respect for patient autonomy. They're getting to get a choice in their care, and being on the ethics committee for 25 years, that's important to me, that we get to talk to a patient, give them a parallel choice, let them choose the one that's best for them. Sometimes people don't want to stick them on and off their chest. Sometimes they just want to set it and forget it. So what's in it for the patient? Find the AFib. What's in it for the patient? Let them provide care choices to guide their own care.
Thank you. I just want to thank everyone for joining. We have a full clinical team that will launch this at your facility if you're interested. We dive into clinical workflow, and we really custom cater it to what exists at your system. We know everything's different. You can reach out to anyone at Viz. We're happy to share more. And please share your questions after the fact. We'll get all the answers and we'll share out the recording. I thank you both, Dr. Hsu and Dr. Meyer, for joining. And everyone have a great rest of the day.